Good morning everyone. Today we are moving to the lecture gonococcal and non-gonococcal infection, which is also known as gonorrhea or the clap, is sexually transmitted infection caused by the bacteria Neisseria gonorrhoeae. The symptoms, which can include unusual discharge, pain while urination, pelvic pain, sore throat, itching, soreness, and however the gonorrhea often doesn't cause symptoms but making it easy to spread other without realizing it. As for the clinical manifestation, asymptomatic, symptomatic, and local manifestations are there, local complications are there, and apart from that, DGI is there, disseminated gonococcal infections. For the gonorrhea, common symptoms in men: penile discharge is there, painful burning sensation is there, and painful urination. Testicular swelling is there, and for the women's, vaginal discharge, burning maturation, then bleeding in between periods. Urethral infection in men: acute urethritis is most common in men. Incubation period, which is 1 to 14 days or even longer. Other symptoms like a urethral discharge or dysuria will be there. Initially, it is scant appearance and mucoid or mucopurulent in appearance, and dysuria, which is usually begins after onset of discharge. Variable degrees of edema and erythema of urethral meatus commonly accompanied gonococcal urethritis. As for the men, we should use the squeeze technique. Urogenital infection in women: primary site, endocervical canal, urethral colonization, which is 70 to 90% of infected women, but it is uncommon in absence of endocervical infection. Infection of battering gland ducts is also common. For the incubation period, which is usually 10 days. For the diagnosis purpose in men, we will use this press and squeeze test technique, and for the women, we will diagnose it by the help of perspeculum examination. Okay, the most common symptoms are those of most lower genital tract infections in women: increased vaginal discharge, dysuria, in between bleeding will be there, and menorrhagia. Purulent exudate occasionally may be expressed from urethra or Bartholin gland duct. Rectal infections: rectal mucosa is infected in 35% to 50% of women. With gonococcal cervicitis, only rectum is involved in 5% of women, 40% in homosexual men. Symptoms range from minimal and anal pruritus, painless mucopurulent discharge, or scant rectal bleeding, to symptoms of proctitis, including the severe rectal pain and tenesmus and constipation. External inspection is there, and anoscopy also present. Complicated gonococcal infections: local complication for men, there will be epidermitis, penile lymphangitis, post-inflammatory urethral strictures, and periurethral abscess. For in women, PID. Most common complication of gonorrhea, as well as the most important in terms of public health impact. 10 to 20% of those with acute gonococcal infection. And abscess is also present. Systemic complications, which is like DGI, disseminated gonococcal infection, more common in female, which is usually manifested by acute arthritis, dermatitis syndrome, which is most common in systemic complication of acute gonorrhea. Classic skin lesion of gonococcal dermatitis, attended necrotic pustule on an erythematous piece, may present as macule, papule, pustules, petechiae, bullae, and ecchymosis. As for the lab investigation, we can go for the gram stain, where you can see the negative gram diplococca in PMN, and culture, which we are doing by the help of a medium which is known as modified Thayer Maton medium. Oxidase reaction is there, which is for to identify the gonococci from mixed culture, and a drop of tetramethyl p-phenylalanine hydrochloride is poured over suspected colonies, which turn pink and then dark blue. Non-culture diagnostic techniques are there, which is known as NAT, which means nucleic acid amplification test, and thus the PCR transcription mediated amplification and other nucleic acid amplification technologies were used. Most which means more sensitive than culture for gonorrhea diagnosis, and specific, which are nearly high for culture. Immunological or biochemical reduction of gonococcal antigens or metabolic products include surface protein, endotoxin, and oxidation. Other enzymes which also have been investigated in past but currently seems less promising than the nucleic acid detection. The fluorescent conjugated antibodies detection which may give positive result 24 hours before conventional culture technique. Serology diagnosis complement of fixation test is there, then rapid carbohydrate utilization test, which is for to detect the beta lactamase production by an SRA species. The detection by change in color of phenol red pH indicator from red to yellow. Treatment: uncomplicated gonococcal infection of cervix, urethra, and rectum, which you can give single dose of tabcefixim 400 mg, ceftriaxone 125 mg, or IM you can give. Then, if chlamydia infection is not ruled out, we can go for azithromycin 1 gram single dose. Uncomplicated gonococcal infection of pharynx, you can give single dose of injection ceftriaxone 125 mg. Plus, if chlamydia is not rolled out, you can give the azithromycin. TGI, which is injection, which you can give ceftriaxone gram IM or IV, or alternatively you can give this ciprofloxacin, ceftriaxone, cefixim, etc. Then gonococcal conjunctivitis, which you can give the injections ceftriaxone. If it is meningitis, you can give the ceftriaxone. Endocarditis, you can go for ceftriaxone, then etc. Management of sex partners is needed, which means all sex partners of the patient who have gonorrhea infection should be evaluated and treated for both gonorrhea and C. trachomatis if their last sexual contact with the patient was within 60 days before onset of the symptoms or diagnosis. Follow up: treat the patient with CDC regime. Need not to follow up to confirm their cure, but the patient with persistent symptoms may be tested for antimicrobial susceptibility and other source cause and test accordingly. So these are the flow chart for the management of urethral discharge. The symptom for the men depends upon their urethral discharge. You should go for the proper history. Then examination, you should look for the urethral meatus. Is there any kind of redness or swelling over there? And the type of discharge, is it a creamy, greenish, or a yellowish appearance or not? Then you can go for the lab investigation, which means the gram stain things. Apart from that, you can go for the treatment. Like the treatment should cover all the three organisms, which means tabcefixim you can give, azithromycin, stat. Then the symptoms persist over there, then the patient or partner, we can give the secondozin. Then follow-up is needed for the 7 days. Management of vaginal discharge symptom, you should take the proper history, whether it is burning sensation present or not, backache is there, etc. Then you should go for the post-speculum examination. In the case of vaginitis, is there any presence of candidiasis, bacterial or mixed infections? And for the cervicitis, you have to check whether any kind of erosion or any kind of ulcer formation there or not. Lab investigation, which like wet mount, you can go for it. Chaos, you can go for it. Then gram stain. Apart from that, you can the treatment side, which means if it is vaginitis, in the case of tracheo or bacterial or candidiasis, you can give the tab fluconazole, which is stat, or else clotrimazole you can give in this case. And cervical infection, which is the tab like cefixim, you can give. Moving to gonococcal infections. So for the urethritis, which means infection in the urethra, which is broadly classified into gonococcal and non-gonococcal. In the case of gonococcal, you can see the Neisseria gonorrhoeae, about the non-gonococcal, which is broadly classified into bacteria, viral, fungal, protozoal, mechanical, or chemical. So, which I told, urethritis, which means the inflammation of urethra. Most episodes are caused by the infection caused by pathogen that enter the urethra from skin around urethral opening. Incubation period 7 to 21 days. Clinical features like dysuria will be there, itching will be there, and discharge. Complication, epidermitis, urethral stricture, and transmission. Treatment, which you can give the doxycycline, azithromycin, etc. So this is known as urethral stricture, epidermitis. Then moving to chlamydia for the infections in men, urethritis will be there, epidermitis, proctitis, conjunctivitis, and Reiter syndrome, associated with the symptoms of rectal pain, bleeding, mucopolon discharge, and diarrhea. Infection in female, most infections are asymptomatic: urethritis, bartholinitis, mucopolon cervicitis, vaginitis, vaginal discharge, endometritis, salpingitis, PID, and Reiter syndrome. Genital chlamydiasis may cause infertility, ectopic pregnancy, premature deliveries, and perinatal morbidity. Lab diagnosis, specimen collection is needed, which means urethral scraping, cervical scraping, urine, and other specimens like semen, which aspirate from the fallopian tube. Then we'll do the pap smear, which we do in like clockwise and anti-clockwise direction. Microscopic examination, which means they are gram-negative chlamydial elementary bodies and inclusion. Better they stained by the GIMSA, then inclusions bodies surrounding the nucleus. Then immunofluorescence, more sensitive and specific method of microscopy by using these monoclonal antibodies. Both inclusions and extracellular EB can be identified. Treatment, drug of choice, doxycycline in adults and erythromycin in infants. Since the chlamydia have longer replication cycle, hence short course will only suppress infection. The treatment should be given for a minute of 7 days, 3 weeks in women with ascending and complicated genital infection. Erythromycin provides sustained level in tissue. Infections which is caused by the ureaplasma, NGU, epidermitis, vaginitis, cervicitis, and may cause chorioamnionitis, prematurity, postpartum endometritis, chronic lung disease of premature infant and female. For the male and female, they might have infertility. In the case of lab, you can collect the semen, urine, and biopsy. So, oculogenital syndrome, NGU, and conjunctivitis may be seen in 4% of patients and respond to tetracycline. Reiter syndrome, some cases of NGU also present with arthritis, uveitis, and few cases against antibiotic associated with colitis. Most dysenteric Reiter syndrome and are more common in HLA-B27 positive patients. Features like initial manifestation within 40 days of exposure, urethritis may be mild, and other features develop after 1 to 5 weeks. Arthritis, which is develops in 4 weeks, knees, ankles, small joints are involved in this. Dactylitis, mild, bilateral, conjunctivitis, keratitis, etc. and dermatological manifestation occur in 50% of patients. It include waxy papules, central yellow spots, most on soles, palms, nails, and scrotum, etc. And the initial episode of Reiter's, which is lasts for 2 to 6 months. Lab diagnosis: anemia, increased ESR, and decreased glucose and joint fluid. Therapy like anti-chlamydia therapy, tetracycline, and non-steroid and anti-inflammatory drugs. Thank you for listening my lecture. Have a nice day.